Good afternoon or good evening, everyone. My name is Amir Najat, and I'm full-time faculty at Louisiana State University School of Dentistry. Today, I'm really excited that I'm presenting you ceramic and cementation choices to optimize function and aesthetics. Before we start the presentation, I would like to disclose that today's presentation is kindly sponsored by Curare. Also, I would like to thank all my mentors over the years that has played a vital role in my growth. I would like to dedicate this lecture in memory of John Burgess, who passed away last year and left us a great void. Today, the world of restorative materials is shaping every day. There are new technologies that are changing the materials, there are new materials coming to market, and we all seek long-term clinical success. So question becomes, how do we know when there is a new material coming to market, that material is going to have a place in our armamentarium and we would like to use it in our clinical practice? For instance, let's take a look at this case. A young individual comes in with a chief complaint that now he's getting sensitivity on his teeth. And when we evaluate it, we find out that he has worn down enamel. And when he goes through excursive movements, we can see that he has lost his canine guidance and now he's in group function. And we know over time he will start breaking cusp, and we have to do a rehabilitation for him to prevent further tooth loss. But the question becomes, if he has lost the enamel, the God-given enamel, in such a short period of time, what would be the best material of choice to ensure that that rehabilitation would last as long as possible? Or let's take a look at this case. A young individual comes in with a history of trauma to his face, which has resulted in an endodontic treatment of tooth number 9 that we can see now is discolored. He also has some spacing, diastema, that he would like to close them, and he would like to get a nice smile. Or we can see that this individual, when she comes in, her chief complaint was that she doesn't like her anterior restorations. She has a veneer on tooth number 8, and she has a crown on tooth number 9, and we can see they obviously do not match. What would be the best cement to use in this case? What would be the best ceramic material used to in this case? Or when we have a very young individual that has a missing lateral, a peg lateral on one side, a missing lateral on the other side, and she just wants a normal smile so that it would boost her confidence in school. Now the question becomes, which material would serve our purpose best? So in today's lecture, we're going to go over a classification of indirect restorative materials. Then we're going to touch on resin cements and what are the different resin cements we have available today that we can use. And finally, we would go over material selection in different clinical scenarios to find the best combination of restorative material and resin cement to gain long-term success. Now, we do have a very wide range of materials with different names from different brands available for us. The question becomes, how can we make it simplify so that this long list of materials would not confuse us as a clinician, and we would be able to navigate a new material, how we can use it, which clinical scenarios, and how do we fit it in our practice. So probably one of the best ways to classify and simplify the classification for all these ceramics would be based on their composition. We can simply classify all these materials into 3 main classes. The glass matrix ceramics, the ones that they have a glass face, and then it has filler particles embedded inside that glass matrix. the ones that have a resin matrix and would have filler particles embedded in them, resin matrix ceramics, or the polycrystalline ceramics. Now we can simply put all these materials into one of these categories and navigate their properties and possible and potential clinical implications. The first group of glass matrix ceramics. This group can further divide it based on the filler particle used, can further divide into 4 subgroups: feldspar reinforced, lucite reinforced, zirconia reinforced lithium silicate, and lithium disilicates. For a long time, we have used feldspatic porcelain and feldspar reinforced ceramics for our restorations. They do have limited amount of crystalline phase and a relatively lower flexural strength, but they offer a high amount of optimization and characterization when we deal with aesthetic zone. At the same time, they add a weak link that might lead to some prosthetic complications like chipping, as we can see here. This was a full arch implant restoration and had a chipping on the central incisor, and now so many times the patient may ask us to just patch it and not replace the whole restoration. And the challenge in these cases becomes how well does composite bond to ceramics, to feldspathic porcelain. And we know that over time the composite can discolor and it can have a negative aesthetic effect on the restoration. In these cases, my material of choice is a combination of Clearfield Universal Bond Quick 2 that has 3 distinct primers inside it, including the original MDP primer, a unique amide primer that is extremely hydrophilic and it turns hydrophobic as soon as it polymerizes. And now we have the urethane tetramethacrylate monomer has been added in order to create a strong uniform bond. So this is my choice when it comes to these cases, that I have different substrates and I don't want to keep changing my adhesive. Then I would love to use in these cases the Universal, the Clearfield Majesty ES2 Universal. And we can see that these composites have light diffusion technology, or LDT, and it really makes the restoration diffuse light very close to the substructure. And as a result, we really can see a nice margin, a smooth integration to the restoration or to the tooth structure, and we get really excellent aesthetic results. This is definitely my material of choice in these cases. Now, the second group of glass matrix ceramics are lucite reinforced ones. They do have high amount of crystalline phase, which makes them slightly stronger than feldspar reinforced ceramics. Then we have zirconia reinforced lithium silicates, which they have high amount of crystalline phase, and around 10%, 10 to 8% zirconia has been added to them in order to increase the strength, which resulted in a higher flexural strength. When we look at them under SEM, we can see that lithium silicates are relatively smaller filler particles and more round when compared to lithium disilicate that are more elongated fillers. And we see that these crystalline structures, they do not prevent the crack propagation as well as lithium disilicates. And that takes us to the last category of glass matrix ceramics, which is widely used, lithium disilicates. They would maximize the amount of crystalline phase to 65 to 70%, and they come with different translucencies from the lowest translucency to highest translucency. They can offer us a range of translucency, and they're easier to mill. For example, IPS Emax CAD is easier to mill in the blue stage, and when it's fully crystallized, it gains the highest strength. And they do have long rods of crystals embedded into each other, which would create a good scaffold so that it would prevent fractures propagating into the material. If we look at this case, this is a young individual that we discussed, number 9, with discolored due to the fact that it has endodontic treatment. Now, with all cases, the first thing we do is that we first determine where is the ideal tooth position by just doing a simple virtual wax up. And with doing that, we found that we have to move the teeth. So we asked the orthodontist to move the teeth accordingly to have a better space distribution. Now, with having the end result in mind in terms of position of the teeth, the question becomes, what's going to be the best material to choose in this case? If you look at the teeth after removing all the composites that exist there, we can see that there is a significant discoloration in tooth number 9 in comparison to others, which can make this case challenging. At the same time, we have to consider the fact that this is a young individual, and hopefully he will have a long life ahead of him, and there might be a chance that he would go through another round of rehabilitation in these teeth. And the more enamel we keep, the higher the chance of success for the next round of rehabilitation. So we decided to do a minimal prep on these teeth and have our talented lab tech Aram Torosian fabricate us beautiful lithium disilicate veneers. And then the question becomes, what would be the right sequence of delivering these veneers? How do we prepare the teeth? What do we select as a resin cement for delivery? When time comes in for delivery of these restorations, the first thing we need to do, we need to make sure we have removed all the temporary cement from the tooth surface. And my material of choice for that purpose is Katana Cleaner. Katana Cleaner is designed to remove any contaminants like saliva, blood, debris, or remnants of temporary cement from the tooth structure. So we do have a bunch of cleaners out there in the market, but Katana Cleaner is the only one that has a pH value of 4.5, have an acidic pH value, which makes it suitable not only to be used outside of the mouth under restoration, but also makes it valuable to be used intraorally on the tooth structure. The way it works is that it contains MDP salts. MDP salts encapsulate the temporary cement remnants on the tooth structure that are microscopic. We cannot really see it with our eyes, but it goes there and encapsulates it and removes it easily. It also can weaken the temporary cement and make it easier to be removed by rinsing and rubbing it. Once we clean the surface with Katana Cleaner, we use the phosphoric acid to etch the surface to create this beautiful frosty looking enamel that is ready to be bonded. Then Universal Bond Quick was added to the tooth surface and air thinned, and then Panavia Veneer LC was applied in the intaglio surface of the veneers and placed firmly on the tooth structure. Now it's going to be really important that we do not create any vibration, any micro movement until the full setting of the cement, because any micro movement can really damage the bond to the tooth structure and it can result into immature debonding of the veneers. I also like to pack cord to make sure there is no excess cement going down to the root surface and help me remove the excess cement. In case of bleeding, we can also use products like OxyGuard in order to make sure that the cement cures very nicely. Now, if you want to talk about the cements, we have a wide range of cements available. One of the strongest cements we have is going to be Panavia V5 cement, which comes with a tooth primer that contains also the dual cure activator, meaning that as soon as the cement is inside the restoration, goes on the tooth, it touches the tooth primer, it starts curing, which is a very smart idea, making the shrinkage of the cement toward the tooth. And then we do have a clear fill ceramic primer, which we will apply it in the intaglio surface of the crown or veneer or any indirect restoration we have. This cement will provide us the best bond strength we can get. Also within the same ecosystem, we do have Panavia Veneer LC. So this cement is designed as a light cure version cement that would enable us to have extra time when we deliver veneers. Also, it has minimal amount of color discoloration over time, which is really necessary for our resin, for our veneers when they're bonded. It can be used a Panavia V5 tooth primer on the tooth sides or the Clear Fill Universal Bond Quick 2, which is great because we're using the same adhesive for our composites, we're using the same adhesive for our veneer cement, and that creates a very nice ecosystem that we can use different components together. We also have the ceramic primer that we apply in the intaglio surface of our veneer. The other version of the cement we have, resin cement we have available from Curare, is going to be our Panavia Cement Universal, Panavia SA. Panavia SA has all the components, MDP, silane, all together, and that's a universal cement we have. So using a Clear Fill Bond Quick 2 is going to be optional, but John Burgess has shown us that if we use the Universal Bond Quick 2, in addition to the Panavia SA, we would gain higher bond strength values. So if you have a dentin substrate and we want to improve the bond while having a minimal number of steps, combination of Panavia SA and Universal Bond Quick would be great. Now, if you want to put these cements together and just have a brief comparison among them, we can say that Panavia V5 is dual cure, Panavia Veneer LC is light cure, and Panavia SA is also dual cure, meaning that even if there is no light, they still cure. And when we add light, it of course cures faster. But Panavia Veneer LC requires us to cure it with a light cure. If not, it will not cure by itself. In terms of the bond strength, we anticipate a really high bond strength when we use Panavia V5 or Panavia Veneer LC. In terms of discoloration, Panavia Veneer LC will give us the lowest amount of discoloration as it's the light cure version. In terms of gel time, self-adhesive resin cement, Panavia SA has the longer one, which means that we have more time after putting it in, after putting the restoration with the cement in the mouth on the tooth structure. We have longest amount of time in comparison to the other ones before it sets. However, Panavia Veneer LC also has a very long working time, if we call it, but that's not the gel time. It's the time that by the time we start curing it, it's going to get hard. We have time before that. But Panavia SA gives us a longer gel time, so it's easier to clean it from the tooth. And that takes us to the last one. In terms of number of steps, Panavia SA has the lowest number of steps involved, so it's the most simple one, easy to use cement. Now, if you take a look at that case, by using a B05 and having a very talented lab tech, we can see that we were able to achieve a very nice aesthetic results. We do have a nice blending of the 4 incisor veneers to the rest of the dentition. And choosing the right material, a lithium disilicate veneer, plus the right cement, Panavia veneer LC, did the magic here. Now, the importance of cement shade and which cement shade we select becomes more evident when we have a case like this. When we take a look at this case, the patient is not satisfied with the mismatch between 8 and 9. And also we can see that the veneer has been fractured. But when we do analyze the case after removing the restorations and after merging it into a digital world to understand that what possibly was the reason that this mismatch has happened, we come to one aspect. So if we do a cross section of tooth number 9 with a crown on it, superimposed to the previous restorations, we can see that it was 2.1 millimeter thick, but the veneer was just 1.1 millimeter thick. So this difference in thickness, that will also be translated to the restorations we will make. So you can see that these two restorations, they look differently. It seems that they're of different shades, and that dominantly comes from the fact that one of them is only 1 millimeter, 1.1 millimeter, and the other one is almost 2 millimeter. This difference in the thickness creates a challenge for us when we select the right cement. One of these restorations is a veneer, so we're going to use Panavia veneer LC. The other one is a crown, and we're going to use Panavia V5. So the question becomes, now that we have two different thicknesses of the restoration, meaning that we have different translucency of the restoration, what would be the material of choice in terms of cement? The cement shade plays a vital role in these cases, as we do have different translucencies. And the great thing about a versatile system is the fact that it comes with the same shade cements within a different resin types of resin cements they have available. In Panavia's system, we do have trying paste, which is very accurate for Panavia V5. And each Panavia V5 cement has a corresponding trying paste that we can easily try on before selecting the cement we would like to use. And the great thing about this versatile ecosystem is the fact that we can go to a different cement, Panavia veneer LC, but still use the same trying paste. Now we have the same trying paste for a different cement. That creates a less number of trying paste that we will need to maintain in our office, and the fact that we can use them for different types of cement. So in this specific case, after doing multiple tries, we used universal A2 shade of Panavia V5 cement for the crown, and then we used the soft white B05 shade for Panavia veneer LC. And the great thing about the versatile system, like the Panavia cement, is the fact that we could use just a tooth primer for both of them on the tooth structure, and the clear fill ceramic primer, we use it both in the intaglio of the veneer and the crown. And we can appreciate the fact that with the talent of the technician we have, and with choosing the right cement, we were able to match these two much better than what it was before. Let's take a look at what it was and what it is right now, so you can see that there was a clear mismatch between the opacity of these two restorations, between the shade of these two restorations, and now we were able to do that, to match them really better by choosing the right cement and choosing the right type of material. And of course, having a very talented lab tech being able to match them for us. Now, the question becomes, why do we need to bond restorations? Is it a necessary step? So there are certain occasions we have to bond a restoration. The first is that when we don't have sufficient retention resistance form. Imagine we have less than 3 mm height, or we have a very tapered prep, or maybe we have a tabletop or a veneer. These are really non-retentive. In these cases, to gain that extra retention that we require, we need to use resin cement, and we need to bond the restoration in place. The other factor is the fact that when we have a thin restoration, whether it's veneer or a crown, and it has high translucency, the shade of the cement becomes really important in the final aesthetic outcome. Now, for that purpose, using a cement like resin modified glass ionomer, which has a really high value, looks chalky, really white, is going to affect the shade of the restoration significantly. So we have to use shade of a resin cement in these occasions in order to ensure that we gain the best aesthetic result as possible. Here we can see that with different materials we have available, we do have different translucencies. Some materials will come in much higher translucency than others, which means that they would reflect the shade of the cement underneath much more than the other materials. For instance, zirconia in general has lower translucency than glass matrix ceramics, which means that it's going to be very crucial for glass matrix ceramics that we choose the right cement. Now, when we don't have sufficient thickness of the restoration, as John Burgess has shown us, there's a specific strength that each restoration we expect from it. And when we don't have sufficient thickness of the restoration, we can enhance the strength of our restoration by bonding it in place. So what does a sufficient thickness of each restoration? Based on the manufacturer recommendation, we do have from 1 mm to 1.5 mm on glass matrix ceramics and resin based, and in zirconia from 0.5 to 1 mm. But this minimum thickness is only clinically successful when we bond it in place. For instance, we use a Panavia V5 cement, or maybe we use a Panavia SA. But if we want to just lute it in with resin modified glass ionomer, we have to have a much thicker restoration so that it ensures it does not fracture in long term. We did a study that was funded by American Academy of Fixed Prosthetics, and in that study we found that when the restorations, whether they're 3Y or 5Y, when they were bonded, they became much stronger than when they were just luted with resin modified glass ionomer. And actually that paper won the first place in Tillman Award. And I can say that really proved to me that bonding in place a ceramic restoration can have a significant effect on increasing the fracture resistance of the restoration. Second group of ceramics are resin matrix ceramics, which were introduced with the goal of combining advantages of polymer and ceramic material. Back in 2013, ceramics were only non-resin organic refractory compounds, but then ADA revised its nomenclature and included predominantly inorganic refractory compounds as also dental ceramics, which included these type of materials also as a ceramic material. One of the first materials in this group that was introduced was resin nanoceramic, which contained 88% of nanocluster particles and nanoparticles of silica and zirconia embedded inside a highly cross-linked polymeric matrix. The other example is Vitadynamic, which is polymer infiltrated ceramic network, where two-dimensional networks are interpenetrated each other. It contains 86% of feldspar ceramic as a filler embedded inside a methacrylate polymer. The main advantage of these materials was the machinability of them, and as we did a study back in 2016, we found that when you mill resin matrix ceramics, you have a much more refined margin, less marginal chips, and easier for the machine to mill these restorations. And a new kid in the block would be the 3D printed version of these materials, which contains approximately 50% filler content. And as in 2023, ADA accepted over 50% filler content of a 3D printed material as a final permanent ceramic crown material. And when we look at the different materials we have available, we can see that they have an acceptable translucency and they have a relatively low flexural strength. And we need to remember that one of the main challenges with Love Ultimate was its debonding. We did a study back then and found that it is very crucial we do bond these restorations in place rather than just luting them. It would be the same with these resin matrix ceramics, whether they are 3D printed or whether they're milled. It is important we do the right steps and bond them properly. Third group of ceramics are polycrystallines, which we know zirconia is among them. Polycrystalline ceramics are characterized by lack of a glassy face, and they have grains that are densely packed side by side, resulting in higher mechanical properties compared to glass-based ceramics. At the same time, lower translucency. Now, zirconia has been the topic of many advancements, including the multi-layer technology. So we know that in a natural tooth, we do have enamel on the incisal. As we go toward the cervical, we have less enamel and more dentin, which means that in the incisal edge, we have higher translucency. On the cervical area, we have lower translucency. In the incisal edge, we have higher value, and the cervical, higher chroma. And that's why there has been many advancements in multi-layer technology of zirconia to mimic the natural tooth. One of the earlier versions of Katana zirconia was Katana HD, which had 3 mol% yttria in its content and had very high strength. At the same time, it was not multi-layer. The next generation was a multi-layer version of Katana HD, which was Katana HTML. It was multi-layer in terms of shade, having a higher chroma in the cervical area and higher value on the incisal area. This version of the Katana zirconia had lower translucency and a really high flexural strength. In order to obtain higher translucency value, yttria content was increased to 4Y or 4 mol% in STML and 5Y or 5 mol% in UTML in order to obtain higher amount of cubic phase and less amount of tetragonal phase. We know that tetragonal phase is anisotropic. It reflects the light as it goes through it in the grain boundaries. However, cubic phase is isotropic. The light can go through it from one grain to another. The latest advancement that has been introduced by Katana is Katana YML, which has a gradation of not only shade from cervical to incisal, it also have a gradation of yttria content. In the cervical area, it has lower yttria content, it's stronger, and as it goes to the incisal part, it has higher yttria values, higher yttria amount, meaning that it has higher amount of cubic phase and less tetragonal phase. This has been a revolutionary advancement in the field of dental zirconia. This is an SEM image of zirconia. We can see the grains packed side by side. If we have a trauma, like a crack that has been created inside the zirconia, there is something unique happens in zirconia that we do not have it in other glass ceramics. which transformation of tetragonal phase to monoclinic phase, which is approximately 4% larger grains. And these transformation from tetragonal to monoclinic creates pressure on the crack and stops the crack from further propagation. That is called transformation toughening. Chevalier's group has shown that 3Y zirconia has the highest amount of capability of this transformation toughening, and as we go to 5Y, we can see the line is getting clear and it's not that much ragged, meaning that less transformation toughening has happened. Now, if you want to go back to our case that had worn down his dentition, we need to choose a material that has highest amount of wear resistance. If we assume how much enamel wears enamel itself as a standard for how much wear we should expect on a material in oral cavity, we can see that glass matrix ceramics do wear less when they oppose enamel. We do get relatively higher amount of wear of resin matrix ceramics, but when we look at the 3Y and 5Y zirconia, we don't get much of wear at all. So we can make a conclusion that zirconia, regardless of its yttria content, is a wear-resistant material. But then the question becomes, how about the opposing? How many times we have asked the patient to open their mouth and we see how much a PFM restoration has worn down the opposing dentition? Is it also the case for zirconia or not? The best way to answer is by looking at a systematic review that evaluated 25 studies on the wear of the enamel versus zirconia, and they concluded that the wear of zirconia to enamel group has been similar to enamel group in all the studies, with the condition that zirconia needs to be really polished. Glazed zirconia wears enamel more. A rough zirconia wears it more. It's really crucial to have a very polished zirconia in order to have it as wear compatible as possible to enamel. However, when we checked how much wear of the opposing lithium disilicate we're going to get with different opposings, we could see that enamel and lithium disilicate could wear lithium disilicate to some extent. With a Mark II, which is feldspathic porcelain, did not cause much of wear on lithium disilicate. But look how much wear we're going to get on lithium disilicate from 3Y and 5Y zirconia. This is significantly more, and that puts us in a position that we may need to conclude that zirconia can cause significantly more wear to the opposing glass matrix materials. So as a take-home message, we can say that zirconia would best to oppose enamel or zirconia. When we go back to our case that had worn down his dentition in a relatively short period of time, on the occlusal surface of the teeth we not only observe wear facets, but also we can see evidence of chemical component and erosion. So we decided to use a very resistant and erosion resistant material. We chose Katana HTML in this case, and to make the clinical procedure of delivery simplified, we chose Panavius A as a cement of choice for this case. Our next case, and the last case of the day, is a 17-year-old high school student who is missing tooth number 10 and has a peg lateral on number 7. And he would like to have a normal smile to boost his confidence at school. We know that this is an age that growth can complicate the treatments if we do go through a route of the dental implants. So we decided to keep it conservative. We did a minimal prep on tooth number 7 for a veneer, and we prepped tooth number 11 in order to have a Merlin bridge replacing tooth number 10. In this case, we used the most advanced zirconia we could have, which is Katana YML. Our talented lab tech created these restorations for us, and of course it's not ideal based on the fact that we have asymmetrical space. Patient refused to do ortho to bring the centrals together, so we would have more symmetrical spaces. But we can say that we improved his smile, and hopefully that boosts his confidence at school. Now, these restorations were bonded in on the right side. The veneer was bonded in with Panavia Veneer LC, and the left side was delivered by Panavia V5. And we can appreciate the nice graduation in the restorations in terms of the translucency from incisal ledge to cervical, and we can also appreciate the gradation in the shade from incisal ledge to cervical area. At the end of the day, we do have a wide range of dental materials to choose from when it comes to indirect restorations. While we need to love all the materials we have in our armamentarium, but we need to pay close attention to their mechanical and optical properties so that we choose the right material for each clinical scenario that ensures long-term clinical success. We review 3 different types of ceramics we have available: glass matrix, resin matrix, and polycrystalline, and reviewed some clinical indications of these materials. We also highlighted the importance of having a versatile resin cement system, one that would come with corresponding trying paste, especially useful for challenging cases in aesthetic zone, and one that comes in with a wide range of cements, including a universal self-adhesive cement that minimizes the number of steps, to a dual cure adhesive cement with a very strong bond, to a light cure version that minimizes the discoloration of the cement and is very important to have for veneers. With that being said, I would like to thank you all for being in this lecture. Please don't hesitate to be in touch with me. You can scan this QR code and that will have my contact info, and I would be more than happy to help you with any material selection question you would have. Thank you all very much.
Now, we do have a couple questions that I appreciate them and I would like to answer them in the remaining time. So the first question is that, what is the name of the cleaner we use on the tooth structure? The name of the cleaner was Katana Cleaner. It contains MDP salts and it's water-based. So after applying it on the tooth structure, we can easily rinse it off with water. And that makes the application pretty easy. Now, we do have different cleaners out there, but we cannot use them in the mouth. This is the only cleaner that we can use it on the restoration itself and in the mouth as well. We know that when we try in a restoration in the mouth, saliva will be on the surface of the restoration, the intactor surface, and that can interfere with our bond. We have to use a cleaner in order to remove the phosphates. For instance, in case of zirconia, we can either use cleaners or we can sandblast it or use other products. Whatever we do, we need to clean the surface after we try it in the mouth. And that's where this cleaner comes in use. The second question is that, would sensitivity increase if Katana Cleaner is used along with phosphoric acid? Any use of Glumo in the process? That's a great question. So phosphoric acid has a pH of 0.1 to 0.4. It's really strong. But Katana Cleaner has a pH of 4.5. So it's way milder than phosphoric acid. So we're not worried at all about sensitivity in case of using Katana Cleaner. Also, in that case that we discussed it was all enamel. That becomes more important when we have a dentin exposure. When we use Glumo is essentially glutaraldehyde, and it goes and blocks the dentinal tubules, which can affect the hybrid layer. It can influence the long-term bond degradation. But when we talk about enamel, it doesn't have an influence on enamel. So using a Glumo can be beneficial when we have a dentin exposure, but in those cases, if it's really superficial, we really do not have any sensitivity that we are worried about. And the pH of Katana Cleaner, again, is 4.5. It's not going to pose any risk of sensitivity for us. The other question is that can you use alloy or metal primer instead of tooth primer on titanium abutment for Panavia V5? That's a great question. So we know that bonding to titanium and metal can be challenging. So what Katana provides us is that they tell us maybe you want to use Panavia SA in those cases that contains all the ingredients that you would need in just one tube. And that provides you a very durable and dual cure bond. Now, if you want to use Panavia V5, you can just use the primer that's included, the clear field ceramic primer, and that would be usable in case of Panavia V5. However, Panavia F2 does not allow us to do that. We need to use a separate metal primer. The other question is that if the zirconia is under 1 millimeter thick, what are the best cements that we should use? So when we do have less than a millimeter thickness, for example, in a case that has high functional forces and the it's on the occlusal surface, if you're talking, that really needs reinforcement in the material. And in those cases, the best cements to use are resin cements. For instance, Panavia V5 or Panavia SA if it's a crown onlay. In case of a veneer, then we better use Panavia Veneer LC. And we have another question from a great friend of mine, Dr. Abrego, that asks that what would be your material of choice for a fixed full arch monolithic zirconia restoration and why? So full arch monolithic zirconia restorations area is changing every day. You know, with the introduction of YML, that's bringing in a very different material than we used to use. We used to use 3Y zirconia, like HT, Katana HT or Katana HTML in those cases. Now, Katana HTML is being used by different labs in a very big production level, and it's been successful. And we can use that if that limits the need for layering, that really removes that weak link of feldspathic porcelain layered on top of a 3Y zirconia. That probably would be a great choice in those cases. That's a wonderful question. And as we go, we update the data. But so far, what we know, biggest labs, they love Katana YML and gradient zirconia in general. With that being said, I would like to thank you all. That was amazing. And have a great rest of your day. Thank you.